Welcome to the Dr. Izzy's Medical Podcast channel.
Head and neck cancer. Head and neck cancer develops from tissues in the lip and oral cavity, mouth, larynx, throat, salivary glands, nose, sinuses, or the skin of the face. The most common types of head and neck cancers occur in the lip, mouth, and larynx. Symptoms predominantly include a sore that does not heal or a change in the voice. Some may experience a sore throat that does not go away. In those with advanced disease, there may be unusual bleeding, facial pain, numbness or swelling, and visible lumps on the outside of the neck or oral cavity. Given the location of these cancers, trouble breathing may also be present. The majority of head and neck cancer is caused by the use of alcohol or tobacco, including smokeless tobacco, with increasing cases linked to the human papillomavirus, HPV. Other risk factors include Epstein-Barr virus, betel quid, radiation exposure, certain workplace exposures. About 90% are pathologically classified as squamous cell cancers. The diagnosis is confirmed by tissue biopsy. The degree of surrounding tissue invasion and distant spread may be determined by medical imaging and blood tests. Not using tobacco or alcohol can reduce the risk for head and neck cancer. The Hpv vaccine may reduce the lifetime risk of oral cancer if taken prior to the onset of sexual activity. This is because oropharyngeal cancer typical presence in the 4th, 6th decade of life, and this is a relatively new vaccine. While screening in the general population does not appear to be useful, screening high-risk groups by examination of the throat might be useful. Head and neck cancer often is curable if it is diagnosed early, however, outcomes are typically poor if it is diagnosed late. Treatment may include a combination of surgery, radiation therapy, chemotherapy, and targeted therapy. Previous diagnosis and treatment of one head and neck cancer confers higher risk of developing a second head and neck cancer or recurrence. Signs and symptoms. Symptoms predominantly include a sore of the face or oral cavity that does not heal, trouble swallowing, or a change in the voice. In those with advanced disease, there may be unusual bleeding, facial pain, numbness or swelling, and visible lumps on the outside of the neck or oral cavity. Head and neck cancer often begins with benign signs and symptoms of disease, like an enlarged lymph node on the outside of the neck, a hoarse-sounding voice or progressive worsening cough or sore throat. In the case of head and neck cancer, these symptoms will be notably persistent and become chronic. There may be a lump or a sore in the throat or neck that does not heal or go away. There may be difficult or painful swallowing. Speaking may become difficult. There may also be a persistent earache. Other symptoms can include a lump in the lip, mouth or gums, ulcers or mouth sores that do not heal, bleeding from the mouth or numbness, bad breath, discolored patches that persist in the mouth, a sore tongue, and slurring of speech if the cancer is affecting the tongue. There may also be congested sinuses, weight loss, and some numbness or paralysis of facial muscles. Squamous cell carcinoma of the mouth. Squamous cell cancers are common in areas of the mouth, including the inner lip, tongue, floor of mouth, gums, and hard palate. Cancers of the mouth are strongly associated with tobacco use, especially use of chewing tobacco or dipping tobacco, as well as heavy alcohol use. Cancers of this region, particularly the tongue, are more frequently treated with surgery than are other head and neck cancers. Surgeries for oral cancers include maxillectomy, can be done with or without orbital exoneration. Mandibulectomy, removal of the lower jaw or part of it. Glossectomy, tongue removal, can be total, hemi or partial. Radical neck dissection. Combinational, for example, glossectomy and laryngectomy done together. The defect is typically covered, improved by using another part of the body and or skin grafts and or wearing a prosthesis. Squamous cell carcinoma of the nose. Paranasal sinus and nasal cavity cancer affects the nasal cavity and the paranasal sinuses. Most of these cancers are squamous cell carcinomas. Nasopharynx. Nasopharyngeal cancer arises in the nasopharynx, the region in which the nasal cavities and the eustachian tubes connect with the upper part of the throat. While some nasopharyngeal cancers are biologically similar to the common head and neck squamous cell carcinomas, poorly differentiated nasopharyngeal carcinoma is lymphoepithelioma, which is distinct in its epidemiology, biology, clinical behavior, and treatment, and is treated as a separate disease by many experts. Squamous cell carcinoma of the throat. Main articles: oropharyngeal cancer and HPV-positive oropharyngeal cancer. Most oropharyngeal cancers are squamous cell carcinomas that begin in the oropharynx, the middle part of the throat that includes the soft palate, the base of the tongue, and the tonsils. Squamous cell cancers of the tonsils are more strongly associated with human papillomavirus infection than are cancers of other regions of the head and neck. HPV positive oropharyngeal cancer generally has a better outcomes than HPV negative disease with a 54% better survival, but this advantage for HPV associated cancer applies only to oropharyngeal cancers. People with oropharyngeal carcinomas are at high risk of developing second primary head and neck cancer. Squamous cell carcinoma of the hypopharynx. Laryngeal cancer begins in the larynx or voice box. Cancer may occur on the vocal folds themselves or on tissues above and below the true cords. Laryngeal cancer is strongly associated with tobacco smoking. The hypopharynx includes the piriform sinuses, the posterior pharyngeal wall, and the postcricoid area. Tumors of the hypopharynx frequently have an advanced stage at diagnosis, and have the most adverse prognoses of pharyngeal tumors. They tend to metastasize early due to the extensive lymphatic network around the larynx. Squamous cell carcinoma of the larynx. Surgery can include laser excision of small vocal cord lesions, partial laryngectomy, which is removal of part of the larynx, or total laryngectomy, which is removal of the whole larynx. If the whole larynx has been removed, the person is left with a permanent tracheostomy. Voice rehabilitation in such patients can be achieved through three important ways: esophageal speech, tracheoesophageal puncture, or electrolarynx. One would likely require the help of intensive teaching and speech therapy and/or an electronic device. Squamous cell carcinoma of the trachea. Cancer of the trachea is a rare cancer usually classed as a lung cancer. Most tumors of the salivary glands differ from the common squamous cell carcinomas of the head and neck in cause, histopathology, clinical presentation, and therapy. Other uncommon tumors arising in the head and neck include teratomas, adenocarcinomas, adenoid cystic carcinomas, and mucoepidermoid carcinomas. Rarer still are melanomas and lymphomas of the upper aerodigestive tract. Causes: alcohol and tobacco. Around 75% of cases are caused by alcohol and tobacco use. Tobacco smoking is one of the main risk factors for head and neck cancer. A major carcinogenic compound in tobacco smoke is acrylonitrile. Acrylonitrile appears to indirectly cause DNA damage by increasing oxidative stress, leading to increased levels of 8-oxo-2-deoxyguanosine and formamidopyrimidine in DNA. Both 8-oxo-DG and formamidopyrimidine are mutagenic. DNA glycosylase NEAL1 prevents mutagenesis by 8-oxo-DG and removes formamidopyrimidines from DNA. However, cigarette smokers have a lifetime increased risk for head and neck cancers that is 5 to 25-fold increased over the general population. The ex-smoker's risk for developing a head and neck cancer begins to approach the risk in the general population 15 years after smoking cessation. The high prevalence of tobacco and alcohol use worldwide and the high association of these cancers with these substances makes them ideal targets for enhanced cancer prevention. Smokeless tobacco is a cause of oral cancer and oropharyngeal cancer. Cigar smoking is also an important risk factor for oral cancer. Other environmental carcinogens suspected of being potential causes of head and neck cancer include occupational exposures such as nickel ore refining, exposure to textile fibers, and woodworking. Use of marijuana, especially when younger, has been linked to an increase in squamous cell carcinoma cases in at least one study, while other studies suggest use is not shown to be associated with oral squamous cell carcinoma, or associated with decreased squamous cell carcinoma. Diet. Excessive consumption of eggs, processed meats, and red meat were associated with increased rates of cancer of the head and neck in one study, while consumption of raw and cooked vegetables seemed to be protective. Vitamin E was not found to prevent the development of leukoplakia, the white plaques that are the precursor for carcinomas of the mucosal surfaces, in adult smokers. Another study examined a combination of vitamin E and beta-carotene in smokers with early-stage cancer of the oropharynx, and found a worse prognosis in the vitamin users. Betel nut. Betel nut chewing is associated with an increased risk of squamous cell cancer of the head and neck. Infection. Human papillomavirus. Some head and neck cancers are caused by human papillomavirus, HPV. In particular, HPV-16 is a causal factor for some head and neck squamous cell carcinomas, HNSCCs. Approximately 15 to 25% of HNSCC contain genomic DNA from HPV, and the association varies based on the site of the tumor, especially HPV-positive oropharyngeal cancer, with highest distribution in the tonsils, where HPV DNA is found in 45 to 67% of the cases, less often in the hypopharynx, 13 to 25%, and least often in the oral cavity, 12 to 18%, and larynx, 3 to 7%. Some experts estimate that while up to 50% of cancers of the tonsil may be infected with HPV, only 50% of these are likely to be caused by HPV, as opposed to the usual tobacco and alcohol causes. The role of HPV in the remaining 25 to 30% is not yet clear. Oral sex is not risk-free and results in a significant proportion of HPV-related head and neck cancer. Positive HPV-16 status is associated with improved prognosis over HPV-negative OSCC. HPV can induce tumor by several mechanisms. E6 and E7 oncogenic proteins. Disruption of tumor suppressor genes. High-level DNA amplifications, for example, oncogenes. Generating alternative non-functional transcripts. Interchromosomal rearrangements. Distinct host genome methylation and expression patterns, produced even when virus isn't integrated into the host genome. Induction of cancer can be associated for the expression of viral oncoproteins, the most important E6 and E7, or other mechanisms, many of them run by the integration, such as the generation of altered transcripts, disruption of tumor suppressors, high levels of DNA amplifications, interchromosomal rearrangements, or changes in DNA methylation patterns, the latter being able to find even when the virus is identified in episomes. E6 sequesters p53 to promote p53 degradation, while E7 inhibits p-ERB. p53 prevents cell growth when DNA is damaged by activating apoptosis, and p21, a kinase that blocks the formation of cyclin D, CDK4, avoiding p-ERB phosphorylation and thereby prevents release of E2F, is a transcription factor required for activation of genes involved in cell proliferation. p-ERB remains bound to E2F while this action phosphorylated, preventing activation of proliferation. Therefore, E6 and E7 act synergistically in triggering cell cycle progression and therefore uncontrolled proliferation by inactivating the p53 and ERB tumor suppressors. Viral integration tends to occur in or near oncogenes or tumor suppressor genes, and it is for this reason that the integration of the virus can greatly contribute to the development of tumor characteristics. Epstein-Barr virus. Epstein-Barr virus, EBV, infection is associated with nasopharyngeal cancer. Nasopharyngeal cancer occurs endemically in some countries of the Mediterranean and Asia, where EBV antibody titers can be measured to screen high-risk populations. Nasopharyngeal cancer has also been associated with consumption of salted fish, which may contain high levels of nitrites. Gastroesophageal reflux disease. The presence of acid reflux disease, gastroesophageal reflux disease, or larynx reflux disease can also be a major factor. Stomach acids that flow up through the esophagus can damage its lining and raise susceptibility to throat cancer. Hematopoietic stem cell transplantation. Patients after hematopoietic stem cell transplantation, HSCT, are at a higher risk for oral squamous cell carcinoma. Post-HSCT oral cancer may have more aggressive behavior with poorer prognosis, when compared to oral cancer in non-HSCT patients. This effect is supposed to be owing to the continuous lifelong immune suppression and chronic oral graft versus host disease. Other possible causes. There are several risk factors for developing throat cancer. These include smoking or chewing tobacco or other things, such as gutka, or pan, heavy alcohol consumption, poor diet resulting in vitamin deficiencies, weakened immune system, asbestos exposure, prolonged exposure to wood dust or paint fumes, exposure to petroleum industry chemicals, and being over the age of 55 years. Other risk factors include the appearance of white patches or spots in the mouth, known as leukoplakia, which in about 1/3 of cases develops into cancer, and breathing or inhaling silica from cutting concrete, stone or cinder blocks, especially in enclosed areas such as a warehouse, garage or basement. Diagnosis. A person usually presents to the physician complaining of one or more of the above symptoms. The person will typically undergo a needle biopsy of this lesion, and a histopathologic information is available. A multidisciplinary discussion of the optimal treatment strategy will be undertaken between the radiation oncologist, surgical oncologist, and medical oncologist. Most, 90%, cancers of the head and neck are squamous cell derived, termed as head and neck squamous cell carcinomas. Histopathology. Throat cancers are classified according to their histology or cell structure, and are commonly referred to by their location in the oral cavity and neck. This is because where the cancer appears in the throat affects the prognosis. Some throat cancers are more aggressive than others depending upon their location. The stage at which the cancer is diagnosed is also a critical factor in the prognosis of throat cancer. Treatment guidelines recommend routine testing for the presence of HPV for all oropharyngeal squamous cell carcinoma tumors. Squamous cell carcinoma. Squamous cell carcinoma is a cancer of the squamous cell, a kind of epithelial cell found in both the skin and mucous membranes. It accounts for over 90% of all head and neck cancers, including more than 90% of throat cancer. Squamous cell carcinoma is most likely to appear in males over 40 years of age with a history of heavy alcohol use coupled with smoking. The tumor marker cipher 21-1 may be useful in diagnosing squamous cell carcinoma of the head and neck. Adenocarcinoma. Adenocarcinoma is a cancer of epithelial tissue that has glandular characteristics. Several head and neck cancers are adenocarcinomas, either of intestinal or non-intestinal cell type. Prevention. Avoidance of recognized risk factors is the single most effective form of prevention. Regular dental examinations may identify precancerous lesions in the oral cavity. When diagnosed early, oral, head and neck cancers can be treated more easily and the chances of survival increase tremendously. Management. Improvements in diagnosis and local management, as well as targeted therapy, have led to improvements in quality of life and survival for people with head and neck cancer. After a histologic diagnosis has been established and tumor extent determined, the selection of appropriate treatment for a specific cancer depends on a complex array of variables, including tumor site, relative morbidity of various treatment options, concomitant health problems, social and logistic factors, previous primary tumors, and the person's preference. Treatment planning generally requires a multidisciplinary approach involving specialist surgeons and medical and radiation oncologists. Surgical resection and radiation therapy are the mainstays of treatment for most head and neck cancers and remain the standard of care in most cases. For small primary cancers without regional metastases, stage 1 or 2, wide surgical excision alone or curative radiation therapy alone is used. More extensive primary tumors, or those with regional metastases, stage 3 or 4, planned combinations of pre- or post-operative radiation and complete surgical excision are generally used. More recently, as historical survival and control rates are recognized as less than satisfactory, there has been an emphasis on the use of various induction or concomitant chemotherapy regimens. Surgery. Surgery as a treatment is frequently used in most types of head and neck cancer. Usually the goal is to remove the cancerous cells entirely. This can be particularly tricky if the cancer is near the larynx and can result in the person being unable to speak. Surgery is also commonly used to resect some or all of the cervical lymph nodes to prevent further spread of the disease. Carbon dioxide laser surgery is also another form of treatment. Transoral laser microsurgery allows surgeons to remove tumors from the voice box with no external incisions. It also allows access to tumors that are not reachable with robotic surgery. During the surgery, surgeon and pathologist work together to assess the adequacy of excision, minimizing the amount of normal tissue removed or damaged. This technique helps give the person as much speech and swallowing function as possible after surgery. Radiation therapy. Radiation therapy is the most common form of treatment. There are different forms of radiation therapy, including 3D conformal radiation therapy, intensity modulated radiation therapy, particle beam therapy and brachytherapy, which are commonly used in the treatments of cancers of the head and neck. Most people with head and neck cancer who are treated in the United States and Europe are treated with intensity modulated radiation therapy using high-energy photons. At higher doses, head and neck radiation is associated with thyroid dysfunction and pituitary axis dysfunction. Radiation therapy of head and neck cancers can also cause acute skin reactions of varying levels of severity, which can be treated and managed with topically applied creams or specialist films. Chemotherapy. Chemotherapy in throat cancer is not generally used to cure the cancer as such. Instead, it is used to provide an inhospitable environment for metastases so that they will not establish in other parts of the body. Typical chemotherapy agents are a combination of paclitaxel and carboplatin. Cetuximab is also used in the treatment of throat cancer. Docetaxel-based chemotherapy has shown a very good response in locally advanced head and neck cancer. In combination with cisplatin and fluorouracil for the induction treatment of inoperable, locally advanced squamous cell carcinoma of the head and neck. While not specifically a chemotherapy, amifostine is often administered intravenously by a chemotherapy clinic prior to IMRT radiotherapy sessions. Amifostine protects the gums and salivary glands from the effects of radiation. There is no evidence that erythropoietin should be routinely given with radiotherapy. Photodynamic therapy. Photodynamic therapy may have promise in treating mucosal dysplasia and small head and neck tumors. Amphinex is giving good results in early clinical trials for treatment of advanced head and neck cancer. Targeted therapy. Targeted therapy, according to the National Cancer Institute, is a type of treatment that uses drugs or other substances, such as monoclonal antibodies, to identify and attack specific cancer cells without harming normal cells. Some targeted therapy used in squamous cell cancers of the head and neck includes cetuximab, bevacizumab, and erlotinib. Gendosine is a gene therapy that employs an adenovirus to deliver the tumor suppressor gene p53 to cells. The mutational profile of HPV plus and HPV head and neck cancer has been reported, further demonstrating that they are fundamentally distinct diseases. Immunotherapy. Immunotherapy is a type of treatment that activates the immune system to fight cancer. One type of immunotherapy, immune checkpoint blockade, binds to and blocks inhibitory signals on immune cells to release their anti-cancer activities. Treatment side effects. Depending on the treatment used, people with head and neck cancer may experience the following symptoms and treatment side effects. Eating problems. Pain associated with lesions. Mucositis. Nephrotoxicity and ototoxicity. Xerostomia. Gastroesophageal reflux. Radiation-induced osteonecrosis of the jaw. Radiation-induced acute skin reactions. Psychosocial. Programs to support the emotional and social well-being of people who have been diagnosed with head and neck cancer may be offered. There is no clear evidence on the effectiveness of these interventions or any particular type of psychosocial program or length of time that is the most helpful for those with head and neck cancer.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.